Thanks everyone for attending our number 5th now, I think, Southeast Asian Regional Healthcare Professionals Network meeting. We have actually had the largest registrants for this network, and we know that many of you will then view it after rather than live. So all the meetings for our Southeast Asia Regional Network meetings are recorded and viewable on the Hello Type 1 site. So there'll be people streaming in, but in keeping with the time, and I think it'd be great to start and welcome everyone to this Southeast Asian Regional Healthcare Professionals Network. I just want to shout out to Dr. Agustini and our Indonesian colleagues who have joined us for the first time as well in this regional network meeting. So thank you so much. And we have 3 speakers, which I'll introduce later. Just for the speakers' purposes, AC will be moving the slides. So let her know, next slide, please. Then it's easier and more efficient. So this is the brief agenda. We'll go to the key achievements and key focus for this coming work plan. And we have Htun, Dr. Ramouy, Dr. Htun and Johanna, who will be giving us some of the session talks. Then we'll have an open floor meeting and really for all of us who are present to share our thoughts, our best practices, our concerns, our innovative ideas for the next year ahead. Okay, so next slide. For those of you who are, a few of you are also new to the first network meeting here, I'm just going to talk about some of the Action for Diabetes key achievements and our focus for this year. That's a picture of Jerry and me at ISPAD, by the way, presenting some of the many posters that we presented at Abu Dhabi ISPAD last year. Okay, next slide, please. One of the big achievements we've had is really the A4D Action for Diabetes won the really prestigious ISPAD Prize for Innovation in Pediatric Diabetes Care. And this prize usually goes to a group or individuals who have shown incredible innovation and success in improving the quality of care in pediatric diabetes. And the ISPAD executive team and its organization obviously awarded Action for Diabetes this fantastic prize, which Jerry accepted in Abu Dhabi. We were quite busy in 2022 with some of our publications. So we presented at the SP, European Society of Pediatric Endocrinology in Rome, and ISPAD in Abu Dhabi. And we presented several papers, including some oral presentations with regards to our experience in maintaining insulin medical supplies during COVID-19, our innovative platform, Hello Type 1, which many of you have contributed to. So thank you very much. We talked about the development over the last 12 to 15 months of the Southeast Asian Network. And like I said, this is one of our 5th ones I think of. And we also talked about some of the plans to continue to monitor and research into differences of insulin regimen in Cambodia. Next slide, please. We published 2 papers in 2022. These are full papers and first of its kind in Southeast Asia, because you may not be aware, but there were no outcomes for Southeast Asia on the Lancet 2020 Commission for Diabetes. This was a big paper talking about the global outcomes in the world. And when we looked for Southeast Asia, it was not even mentioned. So I think these are really important papers and more to come, because I think we need to highlight what are the gaps that we see in Southeast Asia countries, what we have done, what are the fantastic things that we've done, and what are even prevalence, incidence, and outcomes. So the first paper that we published was on closing type 1 diabetes gaps, which 6 countries contributed to. So thank you to the lead authors who worked with us. We managed to get an idea really over 12 months what Southeast Asian HbA1c outcomes are like, what were the staffing like, whether MDTs were present, what were the universal health coverage, so which countries provided free insulin, free glucose monitoring, etc. Our second paper, led by Professor Ni Lek, I'm not sure if he's here, but again, thank you to him. We analyzed for the first time the 5-year outcome of type 1 diabetes on Laos, and this was a whole country analysis because prior to 2016, no child, adult person survived type 1 diabetes. So a really, for us, a groundbreaking study. Up until literally end of 2022, we have formed new partnerships and collaborations, and this is another fantastic achievement of the A4D team, as well as with many of the collaborative societies. So an MOU is now to be signed with ISPAD, International Society of Pediatric Adolescent Diabetes. An MOU has been signed by the Diabetes Association of Thailand and the Thai Association of Diabetes Educators, and an MOU has been signed with the Myanmar Society of Endocrine and Metabolism. So thank you again for many of you who are here, who has really helped pave the way to close the bridge that we are seeing for type 1 diabetes. And we hope many more MOUs to be signed over the next 12 months. Next slide, please. This is just a brief look. So you can go into our A4D website as well as the Hello Type 1 website to look at free access to the journal publications and what we have presented about the Southeast Asia type 1 diabetes outcomes. They're all freely available to you via the website. Next slide, please. We obviously also expanded our clinic support program, and we have 35 new patients now recruited, and almost 700 people are now supported directly by Action for Diabetes. And I've always said one of the most unique USPs about A4D is when we support a child or young person, whether it is insulin or blood glucose strips, as well as hospital treatments like DKA or retinopathy. We support them until they're 25 to enable them to hopefully have an income to then support themselves, because many of the stories that we hear is that it's too expensive. They don't have the income or the money to buy insulin. They don't have the income or money to buy blood glucose testing strips. And we need that to monitor and achieve optimal glycemic management. And in December 22, we also organized the Diabetes Family Camp in Mandalay. This was in partnership with CDIC, the Novo's group of program, with the Myanmar Society of Endocrine and Metabolism. So this is the picture on the right. So fantastic achievements, because we had to halt a lot of our family camps over 3 years because of COVID-19. And we're really pleased the success of these camps are restarting over the next 12 months now. So next slide, please. Another big achievement is the further development of Hello Type 1. Of course, this is led by a fantastic AC, and it's an innovative digital education resource platform to enable families, caregivers, people living with type 1 diabetes, and healthcare professionals to access really good resource validated type 1 information education. It also allows peer support. There are 2 sections to it. So if you haven't actually seen it, will you please access it? For the healthcare professionals, you do need to register, but for the family caregivers and people living with type 1 diabetes, you can simply access it. The novel thing about Hello Type 1, which I think is really one of our shining stars, is that it's in local languages. We want to keep it in local languages because we know English is not everyone's first language in Southeast Asia. I grew up in Malaysia, I studied in Singapore, so we know that how important it is to have native local languages. Now, we have huge numbers now. In each time, the numbers from the data analytics are getting bigger. We have over 1,500 followers now on the Facebook pages, which is part of the Hello Type 1 ecosystem. But we use the Facebook as well as the website to provide these resources for people and healthcare professionals. And we've also undertaken 3 successful online workshops using Facebook Live in Cambodia. So thank you again to our Cambodian colleagues who has run this with us. So next slide, please. So 2023 is going to be a very busy year. You can see that we are due to publish 2 further papers. One is the Hello Type 1 publication based on our 12 to 15-month data analytics. We hope to continue to analyze the Cambodian insulin regimen in the 2 large Cambodian tertiary hospitals. And again, this hopefully will be led by Professor Nilik from Singapore, working with our Cambodian colleagues. And we are also going to launch Bahasa Malaysia very soon. And actually, we've launched Bahasa Malaysia in 2023 this year, and we hope to work with our Indonesian colleagues. I see Dr. Agustini here to launch Bahasa Indonesia, and then hopefully Bahasa in Philippines as well, in Filipino. So we have 4 new languages that we want to launch. We only recently launched a Thai version, so thank you again to Prof. Tanini and her colleagues. We want to expand and enroll a further 300 over new patients into our clinic support program, and we want to start implementing this program in Indonesia and the Philippines. So we will be working very closely with our colleagues in these 2 countries to support the families and people living with diabetes there. On the bottom left, we also want not to forget the importance of psychosocial support and importance of mental health. So our Hello Type 1 Facebook pages will have a new focus on peer-to-peer support, peer empowerment and engagement. And, we'll have a Type 1D ambassador program, and we want to support young people and families and caregivers on how to optimize and manage diabetes well. And we have Johanna who will be talking about this later on, and she'll be a fantastic lead on this. So next slide, please. I want to introduce our first speaker, Andrew Tan, who is our clinical pharmacist at the Sarawak General Hospital in Malaysia. And thank you for this talk. He'll be talking about Diabetes Medication Therapy Adherence Clinic. So over to you, Andrew.
Right. Thank you so much, Prof. May, for the introduction. First of all, I would like to congratulate the A4D team for all the amazing achievements that you've achieved last year, and also for all the key focus and goals for planned out for this year. And thank you for inviting me once again to share a little bit on the Diabetes Medication Therapy Adherence Clinic set up and role in Malaysia. Next, please. Right, so this is where I work. This is the Hospital Umum Sarawak, or in English, Sarawak General Hospital. And Sarawak is the largest state in Malaysia. Next, please. Next again. And that's where I am in Kuching. Right, next slide, please. So before I begin my sharing, I would like to perform a very quick fact check. So in the last 3.5 years or so, we have been experiencing or been facing this battle against COVID-19. And we have been led to believe that COVID-19 has given rise to a lot of deaths. But in actual fact, next please. In 1 year alone, the data from IDF in 2021 alone, the number of diabetes-related deaths amounts to what we have in total to date from COVID-19. So that really gives us a perspective that the true pandemic that we are suffering from is not just COVID-19, but it's diabetes is even more so a fearful one. Right, next please. So my agenda for today will be touching a little bit on the pharmacist involvement in diabetes care, and also introducing what Diabetes Medication Therapy Adherence Clinic, or in short DMTAC, is, and its implementation and setup. Next please. Right, so a pharmacist has traditionally been known as an apothecary, a chemist, primarily providing dispensing services, compounding services, but our role has really been expanding over the last 2 to 3 decades, and it has included clinical pharmacy services, drug information, parenteral nutrition, regulatory, cytotoxic drug reconstitution, ambulatory services, therapeutic drug monitoring, and many, many more. Next, please. So in diabetes care, the traditional single physician focused approach has largely been replaced by MDT, multidisciplinary team approach. And this has now been endorsed by most, if not all, national and international guidelines. And the team members of the MDT includes not only the doctors, but also other healthcare professionals like the nurse educators, the pharmacists, podiatrists, counselors, dietitians, psychiatrists, ophthalmologists, and most importantly, the patients themselves. Right, so pharmacists are in fact very well positioned to be a member of the MDT team, because they are usually the last person that the patient sees. And because of medication dispensing, refilling, we have pretty frequent contact with patients as well. So patients do have pretty good accessibility to pharmacists, and pharmacists can employ their knowledge on pharmacotherapy to help patients monitor their progress. Next, please. So when we are talking about pharmacist-led clinics or programs, there are many globally. In developed nations, they have the medication therapy management in the US, and there are a number of professional bodies certifying pharmacists and other healthcare professionals to provide this service. In the UK, I think they have the Medicines Use Review or practice pharmacists who sometimes are independent prescribers, and also in European countries, Australia, New Zealand, and so on. And in the literature, really, most of these services have shown quite positive and encouraging outcomes. Next. So in Southeast Asia, unfortunately, published data is quite limited. And most of the publications come from Malaysia. There are some from Singapore, Thailand, Indonesia, Cambodia, and so on. However, the amount of information available from the literature is very limited, unfortunately. And there are varying levels of involvement of pharmacists in different countries. Next, please. Okay, so I'll jump straight into Diabetes Medication Therapy Adherence Clinic. Next, please. And in Malaysia, it was first established in 2006 in Penang. And this is a pharmacist-led program that has been pretty well integrated into a multidisciplinary care team. This service or program has been inspired by the MTM model, and it is accessible now at most public healthcare facilities, both hospitals and primary care clinics alike, which caters to about 2/3 of total patients in the country. So that's really how the healthcare system works in Malaysia. Most of the patients go to public facilities rather than private facilities. So we have a very good network and accessibility and contact with patients here in public healthcare facilities. Next, please. And the MTM was built on these 5 core elements: medication therapy review, personal medication record, medication-related action plan, intervention, referrals, and also documentation and follow-up. So this pretty much is what Diabetes MTech is built upon as well. Next, please. So in our protocol, these are the objectives, 7 main objectives of Diabetes MTech. We aim to improve patients' knowledge and adherence to medication. We hope to reduce adverse effects and complications resulting from complicated treatment regimes. We also do a lot of education for patients, regardless it's about diabetes or devices or medication usage. Sometimes we touch on diet as well, lifestyle, exercise, and so on. And we also help doctors to monitor patients' progress in their pharmacotherapy in between visits in particular. And in doing pharmaceutical review, we try to identify relevant pharmacare issues and recommend interventions as appropriate to the doctors. And last but not least, in doing all these, we hope to improve a patient's quality of life. Next, please. So our scope of service, this may differ from various setups in between different facilities, but ideally, we hope to operate within the same clinic during clinic days, which means that we see patients in the same clinic as the doctors do. And in between clinic visits, we normally schedule appointments for the patients to come back to see us, and this is normally done in the pharmacy. Some facilities do it in the clinics as well. And since the COVID pandemic, a lot of patients have been reluctant to come into the hospital in fear of contracting COVID-19. So we have taken a step forward to introduce or to provide virtual consultations wherever applicable. So the duties of a DMTech pharmacist includes not only providing education, but also to perform pharmacotherapy assessments, to pharmacare issues, developing care plans, providing motivational interviewing, documenting all our actions and plans, and also to provide follow-ups. And ultimately, we hope that we can empower patients to be able to self-manage their condition. Next, please. So what qualifications are needed for a pharmacist to be able to provide DMTech service? There are basically two modules. The first one is a full training, a very labor-intensive, very comprehensive 2-week attachment at an accredited training facility. There are many of such, at least 20 in Malaysia. And subsequently, after the 2-week attachment, pharmacists will need to undergo continuous supervision for up to 6 months by the trainer, right? So after completing this program, they would be certified as a DMTech pharmacist. The second one is a short course, eco training, 5-day training done by any qualified DMTech pharmacist. Basically, is to provide cover for the main person in charge in case the person is not available to see patients. Right, next please. So diabetes MTech, we have a fixed criteria, recruitment criteria of patients. And if we go through the list, you have uncontrolled diabetes, you have patients with poor medication adherence, patients who have failed to achieve individualized treatment targets, those with multiple comorbidities and polypharmacy, patients with target organ damage, and those suffering from frequent hypoglycemia. So if we look at this list, it essentially covers most of our patients. So we do not have a strict recruitment criteria per se, but we do identify patients in the clinic, and we do our own selections of patients who agree and consent to join our program. And we also take referrals from doctors as well. Next, please. So in our first visit, right after the nurses register the patients for the clinic, the pharmacist would approach selected patients to give them a brief overview of what DMTech offers and to recruit them if they have consented. And we will perform a baseline assessment of relevant histories, past medical, medication histories, allergy histories, occupational histories, social and family histories. We also perform a baseline assessment on their knowledge and on the disease and device and medication. We also want to know their adherence level before joining the program, and also a rough overview of their lifestyle, diet, activities, the exercises. Okay. Then after doing all these, we would review the vital signs, lab parameters, SMBG, and then provide recommendations based on pharmacare issues that we have identified. We also then move on to set short-term goals and targets for the patients, with the patients. Next, please. And based on our findings and review, we will provide counseling and education tailored to the patient's needs. So I'll come to this a bit later. And after seeing us, we will document all our findings, all the history, clerking, and we will pass the patient on to the doctors. So the doctor will review the patients again and come up with a treatment plan. And depending on each facility, if it's feasible, the same pharmacist would then perform medication dispensing in the clinic itself and provide necessary counseling. But otherwise, the patients would then move on to the outpatient pharmacy to get the prescriptions filled. And the pharmacist, the MTech pharmacist, will then schedule the patient for the next visit, whether it's a virtual visit or a physical one. Next, please. So our program, when we recruit a patient, we follow up patients regularly. And most of these are actually done in between doctor's visits, right? So we can schedule them anytime between 1 to 3 months. We also sometimes, if necessary, we get them to come in weekly or 2 weekly if they are keen. And in doing that subsequent visits, we perform again a review of their achievements so far. And if there's any adherence issues, we will address that. We will review the glycemic control, the SMBG. If necessary, we will look at the technique again. We can discuss patients' progress in the disease, conditions, and complications. If there's deficits in knowledge, we provide reinforcements, and we give them an overview of their performance or their achievements that they have done so far. So after all this is done, again, we will embark on the necessary counseling, reinforcements, lifestyle, education, and so on. Next, please. So again, if it's feasible in the facility, we will provide dispensing services. And usually these subsequent or follow-up visits for DM Tech, we try to schedule it on the same day as they come in for refills, so that we don't inconvenience them to have to take another day off of work or school just to come in to see us, right? So after performing all the necessary counseling, dispensing, education, we then schedule the patient again for the next visit. Next, please. So back to the education modules, the DM Tech has come up with 4 modules in the form of flip charts, right? So these flip charts are educational tools for pharmacists to use for the patients. Okay, as we go through certain modules, the first module is diabetes and oral antidiabetics. Second module will touch more on insulin and SMBG. Our third module will touch on healthy lifestyle, and the last one would be more on diabetes complications. However, these 4 modules are not meant to be shared or done in any particular order. As I said earlier, we identify the patient's needs and we prioritize what needs to be delivered at each session. Right? So education is not only limited to the 4 modules that we have here. Many a time, we may need to provide education and support for patients that are out of the bounds of these education modules. Next, please. And we always remind our patients that we do not just learn from experience, we need to learn from reflecting on experience. So that's pretty much how we engage the patients to enable them to learn that this program is essentially trying to empower them to be able to manage their own diabetes, and not as a pharmacist providing answers to all the questions every time they need it, right? So we teach them to reflect on all the SMBG, the insulin dosing, the carbohydrate counting, so what is the cause and effect, and how they should modify and improve from there on. So they essentially learn to do all these on their own. Next, please. So there are quite a number of publications related to diabetes MTech service in Malaysia. And this was one of the first retrospective case control studies, and there are various randomized clinical control trials as well. Next, please. Next. Next. So these are all RCTs. And next, please. There's one survey assessing patient satisfaction and also medication adherence as well. Next, please. And to summarize from all these studies, in general, the DMTech service has managed to reduce patients' HbA1c by at least 1%. They have also managed to improve adherence and patient knowledge. And about 70–80% of patients have been reported to be pretty satisfied with the service that they have received. So this is largely in agreement with the literature on a global scale. So other pharmacist-led programs and clinics have also reported very similar outcomes as well. Next, please. So to set up such a service on a national level is not an easy task, right? So the major stakeholders involved would be the health ministry, the pharmacist professional bodies. You need to set up a clinical working committee as well. So these people need to come together to come up with the protocol, to discuss the scope, the legal framework, and so on, right? So once this is done, pharmacists need to be trained and certified as well. So a training module has to be drawn out. So this module, this training, what are the criteria, what are the achievements, what are the targets, what are the key education necessary. So once they've completed that, they would be certified, right? So after certification, pharmacists have to go through credentialing process as well, just to make sure that they are performing as intended. And when we come into the institutional level, we need to get institutional approvals from the hospital directors, for example, head of departments, and so on. And slowly we will come to integrate into the multidisciplinary team. So our multidisciplinary team involves not only doctors, pharmacists, we have nurses, nurse educators with us, we have dietitians in the same clinic, we have psychiatrists, counselors doing group sessions, group therapies in the same clinic itself, albeit probably in the next room or so. We also have occupational therapists helping with food check and food advice. So that's pretty much what I have in my team in Sarawak General Hospital. And infrastructure-wise, the setup, we practically would need some space in the clinic for us to provide consultation, to do our assessments and so on. And in the pharmacy, we will need consultation rooms for us to provide the follow-up visits and counseling sessions. If virtual sessions are applicable, we would need, of course, the equipment necessary and educational materials and tools, insulin demo pens, glucometers, all these will need to be provided to assist us in giving the education, right? So next, please. So just to share a few pictures, these two are my colleagues, diabetes and tech pharmacists. And as you can see here, this is our diabetes clinic. So we operate in the clinic on clinic days itself, reviewing patients before handing patients over to the doctors. Next, please. And this picture is one from the primary care health clinic. And again, we have a consultation room where the pharmacist is reviewing the patient. And there you see right in the middle is our flip chart that is used for education. Next, please. Next slide, please. Right. So apart from providing services to patients, we also have annual or regular workshops as a CPD update, right? So last year, about months ago in 2022, we conducted a state-level workshop.
Sorry, can I just say someone's not muted? Okay, they're muted. Thanks, Andrew.
Right, thank you. Okay, so this is a picture of our diabetes state workshop conducted last year. So in this workshop, we provide clinical updates, not just from the pharmacist perspective, but we also invite external or other healthcare professionals to come in, endocrinologists to come in. We have dietitians coming in, and also psychiatrists. And last year, we had a collaboration with chronic kidney disease MTech as well. Right, next, please. And this is a picture of our type 1 diabetes camp that we did last year in conjunction with World Diabetes Day. And this the people in the circle, those are our endocrinologists, our pharmacists, and our nurses. Okay, so in this camp itself, we have also invited counselors to come in with us. We have dietitians here as well, as well as physiotherapists also to get involved. in the group sessions, the games, and so on. Next, please. So this is just a few pictures on patients and family members, team building exercises. Okay, so I would like to end my sharing here with a few key messages. First of all is pharmacists, we can actually play an integral part within a multidisciplinary team when we are managing patients with diabetes. And the impact of this team cannot be underestimated, as you can help a lot in patient-oriented outcomes and also improving quality of life. And the most important of all is that we have to constantly build trust and have an open communication with other healthcare professional members of the team and also with the patient. And with that, I end my presentation. Thank you very much for listening. And in case anyone wants to keep in touch, I can, that's my email right there. Thank you.
Thank you so much, Andrew. That's a fantastic initiative. I don't think even many of the European or UK centers have a pharmacy-led adherence clinic. So I'm going to leave the open discussion for all speakers to the end. So please stay online, which I'm sure there'll be lots of questions on how we commence, how we initiate this fantastic clinic. I'm going to introduce the next speaker now, who is Dr. Ramouy, who is going to talk to us about DKA with suspected cerebral edema. And Dr. Ramouy is from the National Pediatric Hospital in Cambodia. So welcome, and over to you.
Okay, hello, Professor and all colleagues. I'm Ramouy from National Pediatric Hospital, Cambodia. So is it okay that I done a low video right now? Because I think my internet is not stable right now.
Yes, please, that's fine. You sound perfectly clear.
Okay. So next slide, please. My objective in this topic is to demonstrate the case of suspected cerebral edema, to get the experience from expert to upgrade the clinical management of DKA and cerebral edema. Next, please. The patient is 7 years old, female from Kanda province. She was transferred from a private clinic to of a deterioration of consciousness with hyperglycemia. Next, please. History of presentation. Patient, her parent was told about her condition starting from weight loss around 2 weeks, coinciding with increased appetite, more pee than usual. Parent did not attention. She proceeded to fatigue, abdominal pain with repeated non-bilious vomiting. They brought her to private clinic, but the condition was not good and transferred to NPH on 29 August 2022. Next, please. Past medical history. She is healthy children. She completed immunization, follow the national vaccination program. No any medication noted. No allergy. Family is undergo a T2DM condition, maybe both mother and father. No any abnormality noted. Next, please. There is no any anomaly noted during pregnancy. She is a full-term baby, normal birth weight. She is a third children in family, no NICU needed, and no dimorphic feature noted. Next, please. Evolution and management of the cases. Her weight is 130 cm. Her weight is 30 kg. Vital sign is stable. Next, please. General appearance is disorientation. Consciousness with TCS is not good. 12/15. Dehydration around 10%. No convulsion. The system is normal, but we find deep sighing respiration or Kussmaul respiration. Next, please. After we examine her, we check the some blood tests such as CRP, whole blood, CBC, blood group, glycemia, calcemia, bleeding time, electrolyte, then liver function test, kidney function test, including HbA1c, blood culture, and blood gas also. So next, please. At management at EMD ward. Next, please. We give a supportive management such as oxygen, IV fluid, antibiotic, and waiting for the lab result. Next, please. After the result come out, the condition of the patient is still somnolent, post-more respiration, tachycardia with TCS low. We provide normal saline 4 ml per kg per hour, and we did a urine test with the presence of ketone. 1 hour later, the condition is not changed, and we still provide normal saline with potassium because this time we got the result of electrolyte and blood gas as shown in the table. And at that time, we also provide insulin atropine range from 0.06 to 0.07 UI per kg per hour. We still follow up the glycemia every 1 to 2 hours. At 1 letter after insulin infusion, the condition is the same, no any something change, but the glycemia is still high. At 6:30, the condition is still the same. IV fluid we no need we don't change anything else. We use the same dose. Atropine we increase to 3 ml per kg per hour. Potassium is still low. We notice the blood glucose is a little bit low. Next, please. Next day, the condition is not good, still the same. But the glycemia is respond with insulin infusion. So we during the glycemia is decreased, we change IV fluid normal saline to dextrose 5% with potassium chloride at the same dose 4 ml per kg per hour. 2 hours later, conditions still not change. Insulin is we still keep in the same dose. Glycemia is a little bit higher than. At midday, condition still not good. Atropine the same dose and check electrolyte and glycemia again. The glycemia, I think it is stable right now, but the condition is not good. So next, please. At the evening, the patient don't change any condition. We use the same IV fluid, same insulin. Glycemia we check every hour, 1 to 2 hours too, and the glycemia also respond with insulin infusion. Next slide, please. And then we transfer patient to IPD ward. It is an endocrine department. Next, please. At IPD ward, the condition is still not changed. Somnolent, post-more respiration, and vital sign is not bad. We manage her with insulin infusion, but we also worry about the condition because glycemia still respond with the insulin, but the condition is not good. She still have somnolent and TCS still low. Next slide, please. I done it all. On the next day, vital sign is good, but we find heart rate is a little bit high. GCS 9/15. Consciousness is somnolent, good small respiration, and urine is normal in age range. We request head CT scan, but we cannot find any abnormality. We consider to discuss with ICU team, and they said to they request to correct the acid dose by bicarbonate. Based on our guideline, we never add bicarbonate in the patient with severe acidosis. We also discuss with our endocrine team in order to provide bicarbonate. After discussion, we start bicarb sodium chlorures 710 plus normal saline 100 rand 2 hour at around 6:35 p.m. Glycemia was controlled. Glycemia and electrolyte control after finished bicarbonate. Glycemia is under control with insulin infusion. Blood gas is still low. Electrolyte no any changing. Next slide, please. Due to the patient condition is not better, we concern of a condition which was not improved, and we less experience of managing this case with we consider to transfer to other facility. So in this case, we in our department we have managed diabetes with acidosis many case, but we always success with the case. But this one is the new thing that we have learned from that, because we cannot manage the patient, so we try to consider and transfer him to the more experience. So this is our challenge. I really need some experience or expert here who can share how to manage the case. Our challenge, the first is, in the above case, the glycemia is under control, but the clinical symptoms such as GCS is still low and blood gas appear not in accordingly. So should we manage a cerebral edema with normal appearance of head CT scan? The second one is, should we bolus IV fluid in DKA without shock? What is the prognosis? Number 3, we have less knowledge related with using sodium chloride 3% and mannitol. Please tell us. So this is my last slide. Thank you.
Thank you very much, Dr. Ramouy. Okay, I think in the interest of your presentation, I might actually start with the Q&As for this slides, and in our open discussion, any questions for Andrew Tan, we'll talk about that, only because this is a clinical case. So I'm open to anyone. Please do shout out in terms of how you feel the case has gone. So I have a question, Dr. Ramouy. Do you monitor pH, for example, and were you convinced that the child actually had cerebral edema? The GCS seems to be stable, the pH was stable. And my second question is, there is the International Society of Pediatric and Adolescent Diabetes, ISPAD, guidelines for DKA, even for low resource countries. Is that the protocol you follow?
Sure, we always follow the ISPAD guideline.
Yeah. And why do you think bicarb was used? There's no evidence for bicarb use on management of DKA. Are you aware of that?
Yes, we had read the ISPAD guideline too. The bicarb is not the when we use bicarb, it's not the good prognosis for DKA, but we really consider again and again with ICU team. So we delay for many hours to
Yeah.
provide the bicap.
I
At
agree.
our
I mean, even in the UK and Europe, we argue with our intensive care teams, but because they tend to use it a lot, and DK is one of the special conditions that it hasn't shown to have any evidence. I suppose I don't know if anyone else wants to contribute, because I don't want to butt in with all the answers. But for your first, the second question, should we bolus IV fluids without shock? The answer is no. If there is no shock, it's replacement fluids, isn't it? If it's not 5% or 10% dehydration, then I don't think you need to. We tend to give at most 5% dehydration, rather than if the child is in shock. Because the more fluids you give, too much fluids, then your risk of cerebral edema is higher, isn't it? I see Professor Ni Lick there. Do you want to come in and comment? Ni?
Yeah, hi. Yes, yeah, I agree with you that there's no role for bolusing if there's no shock. Correction, we tend to use up to about 7% dehydration if the child is really, really dehydrated. Your first question about cerebral edema, a normal CT scan does not exclude cerebral edema. Yep. I think that's an agreement there. Use of normal saline or mannitol, yes, we do use that for cerebral edema sparingly. We have used it, yes, for neuroprotection.
And I think, Dr. Ramouy, the important thing is recognition of the clinical signs of cerebral edema, isn't it? Was the GCS actually deteriorating? Was the child getting, irritable? Was the heart rate slowing down and blood pressure rising? So these are the signs of cerebral edema. And I agree with Prof. Neelake that CT scan just useless. There's no point doing a CT hit, because you can have clinical signs of cerebral edema with a normal appearance of the CT scan. Yeah. Does that answer your 3 questions, Dr. Ramouy? Dr. Ramouy? I'm just wondering was there any other questions, or if anyone else wants to comment?
I want more questions.
Yeah, sure.
I want to add my challenge.
Sure.
Can you share about using sodium chloride 3% and mannitol, because we never use what is the dose, what is when we need to start it? Or...
Okay. I don't have it right at the top of my head, unless Prof. Neelake, but it's on the ISPAT protocol. I can send that to you if that helps after via AC. Would that help?
Okay. We also have guideline, but you should add me more to be better. And the one more thing is that when we need to what is the criteria for starting sodium chloride? In this case, should we start sodium chloride when
I see. As in, when do you think we should start it? Is that what you mean? When you think there is CE, cerebral edema?
But there is no any symptom related cerebral edema, because it's just only.
Yes. And I think that's my challenge. I think when you are fairly sure that CE, then we give IV mannitol first, then we contact, we might intubate and then start the sodium chloride 3%. So that's when it's fairly clear. I think in this case, I'm not that convinced that, but then there was a lot of other data that isn't there in terms of, you know, was the sodium level low? Was the GCS deteriorating? Was BP rising? Was heart rate slowing? You know, all the other factors helps you make a clinical diagnosis. And I think in this case, I probably wouldn't have started based on if they were all normal. I think I would, because somnolence, so you can get quite tired just from recovery of DKA. Does that make sense? If you were fairly convinced it was cerebral edema, then you could start the cerebral edema protocol. Okay, I'm going. Is that
Excuse me.
clear? Hi, Dr.
I'm Dr. Wata. Sorry,
Oh,
I'm from.
hello.
I want to add something because
Yes, please.
Dr. Ramouy and I have dealt with this case as well.
Yeah.
Actually, this case we have treated this case for 3 days. Actually, the vital signs good. No high blood pressure, and the pulse also good. But the concern is that the consciousness not good, and the GCS from around 12 to 9, something like that, and no vomiting, just like that, and no Kussmaul sign, I think mostly disappear, and glycemia under control, and so but the pH just around 7.1 like that. So the problem that time is that she was hospitalized for 3 days, but her GCS still not good. And our CT scan, okay also, but it's our concern because we have less experience and the concern of the parent also. So in this case, if you see that case, what is your, I mean, what you gonna do next?
I think if you do suspect it, there is, as long as she has, and you did all the appropriate things, you've transferred her to higher facility care, isn't it? And I'm assuming you gave her what, 0.5 to 1 gram per kilo of mannitol first? Was she intubated in the end?
Actually, after she was transferred to another hospital, we also follow up, and
Yeah.
at that maybe from transfer, maybe 2 or 3 hours later after discharging from our hospital, there they also do the CT scan and they see cerebral edema, but just a little bit, not huge. So
was she intubated then? Did
no,
she?
no.
Oh,
They
okay. So you just gave mannitol and 3% to that.
3% and NaCl or mannitol, I'm not sure, but they treat us cerebral edema.
Okay. And like I said, she wasn't intubated. Okay, so I think you have to go by your clinical diagnosis. And if you feel that she was developing CE, which is the topic of your presentation, then, or suspected CE, then you treat as it is. We would tend to give IV 0.5 to 1 gram per kilo mannitol. We would refer to intensive care for possible intubation, neuroprotection. Then we start the 3% NaCl, head up, that sort of thing. And like I said, hopefully she has a very good prognosis. Once the treatments.
She is now okay.
Okay, that's really good because actual diabetic cerebral edema has usually poor prognosis long term.
Actually, I also see the result of CT scan, and I discussed that with the result of CT scan at my hospital, and I discussed with the imaging specialist. They say just not so different, but there they treat us cerebral edema and not her outcome better because of the cerebral edema management, or just maybe she get better day by day. But it is our first experience because she stay at our clinic for 3 days already, so still GCS not good. That's why we.
And I think you did the right thing because, like you said, she wasn't improving as she should have with the insulin and rehydration.
Yeah.
Then actually, well done to your team for you probably diagnosed her as it was evolving. So that was a good call. Okay, I'm going to move on. So thank you very much. I'm sure there'll be other questions, but please hang on when it's open discussion because we're a little bit late and AC is. So we have our next interesting case discussion from Dr. Htun from Myanmar. So Dr. Htun, over to you. It's yet another interesting case for us to all help each other out.
Okay. So thank you very much, Dr. May, for your invitation. So, hi everyone. I am Dr. Htun from Myanmar, mentally, and I'm taking responsibility as a T1D support doctor in mentally clinic. Today, I want to make a quick share about the case of a patient whose SMBG doesn't correlate, the SMBG testing doesn't correlate with the HbA1c result, so that I can get your experience, like the kind of case in your clinic, and get your advice to get the better outcomes of this patient. So I was just sharing about the case. This is the case summary. It's a case of 17 years old girl, diagnosed since 2016, presenting with the osmotic symptoms, high blood glucose level at the hospital, and the urinary ketone positive and HbA1c over 13.4%. And she was referred to our clinic at 2017. At that time, the regime was 2 times pre-mixed 30-70 injection with a dosage of 1 unit per kg per day, and the HbA1c result was 8.2%. So at the beginning, she was injecting the mixed 30-70 before the breakfast in the morning and before the dinner. At the end of 2018, the regime was changed to basal bolus with the human insulin. So she was given 3 times pre-meal atropine injections and 2 times injections of insulatol before breakfast and the dinner, due to the reason of poor glycemic control. And May 2021, the regime was again changed to basal bolus with the insulin analog. So we gave 3 times pre-meal novorapid injections and 2 times injections of levemia before the breakfast and the dinner. So after changing to insulin analog, she was suffering from frequent symptomatic hypoglycemia. Right now, currently, she is injecting 3 times pre-meal injections of novorapid and 1 time injection of glargine at the night. So this is the case summary. So next, please. So this is the glycemic control summary and the treatment summary. So you can see, so that you can see her glycemic control together with the regime. So in 2017 and 2018, she used pre-mixed 30-70 mixed, and at that time the average HbA1c was around over 10% in that 2 year, and mostly at that time her SMBG result mostly hyperglycemia. The dosage was adjusting between 0.5 to 1.2 unit per kg per day. And in 2019, at the end of 2018 and start of 2019, the regime was changed to basal bolus with the human insulin, and the average A1C throughout the year is 10.75%. And at the time also hyperglycemia, and the dosage was over 1 unit per kg per day. And 2020, the average A1C was 8.3 at only that year. The average A1C was reduced, and the 10, the regime was basal bolus with the human insulin. And at the start of 2021, again, the average A1C was increased, and so we changed the regime to basal bolus with the insulin analog. So novorapid and levemia due to the poor control and frequent hypoglycemic attack. So I will share you the current condition of this patient. Next, please. So it's from 2022 to the present. So throughout the last year, the A1C throughout the year 3 monthly is over 12% of HbA1c. Right now, she is using beta bolus with the insulin analog with a dosage of 0.7 unit per kg per day. So right now, the current problems for this patient is symptomatic hypoglycemic attack throughout the day, but the HbA1c is not decreasing. So let's see. Sorry, this is the current dosage. We gave the Novorapid around 7 units for pre-meal and Insunova G-Clargine 20 units at 8 p.m. So let's see her latest SMBG result. So next, please. So this is the SMBG result of the previous 60 days. So this is the fasting sugar. As you can see in the picture, the results are mostly between 2 and 4 millimole per liter in the morning, always hypoglycemic attack. And there were only 2 to 3 times of hypoglycemia in the morning, and the patient is having symptoms of hypoglycemia in most of the morning. Next, please. So this is the result of 2 hours after the breakfast. So it's also between 2 to 8, around 6, mostly milligram per deciliter, and sometimes it's higher than the normal, but mostly in the hypoglycemic state after the breakfast. But in the apart from the early morning, she never has the symptoms of hypoglycemia throughout the day. The next, please. Also, before the lunch, hypoglycemia, mostly between 2 millimole per liter and around 5 millimole per liter. No hypoglycemic symptoms. Next, please. Before the dinner also, between 2 to 5 millimole per liter, no hypoglycemic symptoms. Next, please. So it is also the for the 2 hours after the dinner, mostly hypoglycemia, but not symptomatic. She has to eat some snacks before bed to avoid hypoglycemic attack at the night. So that's all. So next, please. So we can see that after changing from human insulin to insulin analog, she was suffering from frequent hypoglycemic attack, and the SMBG record, like the previous 60 days, is the same after changing to insulin analog. So that we have to think about why. But as you can see in the presentation, the HbA1c throughout the year in 2022 are all over 12%, and it's not much with our SMBG daily SMBG testing. So we think why does that happen? So the first thing and the easier things we can check is about her record, and so the record is right, and so we try to we give her the new glucometer, and we did the calibration of our HbA1c portable HbA1c tester. So after 3 months, the result was not changed, and HbA1c is always high, but the SMBG results are always mostly in hypoglycemic state. So the next thing we have to think about is complication and the anemia that can alter the HbA1c result. So we did the complication test in the end of 2022. So next, please. So as you can see in the result, we didn't see any abnormalities that can affect the HbA1c level, apart from the increase of total sorry, I have a wrong input, I think. And so she has a increase to the cholesterol and increased LDL. Apart from that, the other results are within the normal range. Next, please. And also, she doesn't have anemia that can alter our HbA1c result. So that's all that I want to share. Right now, we are planning to transport out this patient to the endocrine clinic to have a better outcomes and the result. And right now we are focusing on her daily SMBG result because most of the time she is getting the hypoglycemia attack. So we are reducing the insulin dosage to avoid the hypoglycemia attack throughout the day. But what we have to dealing with is the patient's consent, because the family and the patient also know that the HbA1c is the indicator of the diabetes control, and so they know that is not within the normal range. So they have a concern about the diabetes, about her diabetes control. That is what we have to discuss and communicate with the patient. So that's all for my case, and I want to hear from you all about the kind of experience in your clinic and how we can solve that problem. What is the solution of this problem? So thank you very much for your attention.
Thank you so much, Dr. Htun. A really interesting dilemma that a lot of us have, isn't it? It just is not consistent with the HbA1c and the bloods. I'm going to invite anyone to comment, please. So you can either type it in or you can just speak out. And I'm really glad to see Dr. Estrada from Philippines here. So welcome to your first network meeting. And we've got Dr. Vatsana from Laos, and we've got Dr. Vuta and Dr. Piran from Cambodia. So anyone is happy to comment on this interesting case. Prof. Neelek from Singapore, he's mentioned, Dr. Htun, first thing he would suggest is to bring the child into hospital for a few days. Then you can monitor. One is she actually injecting the insulin? Is there actually those persistent hypos throughout the day, isn't it? Really low. I'm hoping that the glargine has been reduced. And again, is it true record of what she's writing? We have patients that we know that's just writes 246824. So that's a possibility. Dr. Mani is asked, how is the SMBG recorded? I'm assuming on a diary. Is that right? She just tells you what it is. Yeah. So we don't know for sure. I can't see anyone's hands up, but because my screen is limited. So just speak up if you have any thoughts on this interesting case. Can I ask if there is carb counting, is there a dietitian to teach her how to adjust the insulin to her meals, or the 7 units 3 times a day is a fixed dose?
Yeah, actually we don't have dietitian in our clinic, but we calculate her carbohydrate requirement throughout the day according to her age, and calculate and convert it into the carbohydrate content that she has to eat throughout the day. Okay, so yeah. So this is the situation in Myanmar, for those of you who don't know. So there isn't, and I think Dr. Estrada has asked whether there's adjustments being done. So this is carb counting, whether they're taught to adjust insulin before their meals on how much food. And the answer is unfortunately no, this is not available in Myanmar. So you're looking at her foods and she's asked to eat roughly the same amounts each time, and then you give her fixed doses. And like I said, her fasting morning is just so low. It's low all the time. Is the 20 units of glargine too much for her? But I think the important one is really what Prof. Neelek has suggested. You need to bring her in, isn't it, to see the real picture. Is that even possible in Myanmar? Yeah, it is possible, but the condition is we can check her glucometer. We can see the history and with the testing time. She always write the record in the paper, and we can check whether it is correct or not. And we can see that this patient is reliable and
Okay.
al-
So what
always
meter?
the service. Yeah.
What meter are you using?
Performer, acute check performer.
AccuCheck. And so you can look at her meter and you can actually see 2 millimoles, 3 millimoles. So she's
And
actually
no, in milligram per deciliter. We can
Sorry?
see the unit is in milligram per deciliter. So we can convert it into millimole per liter. Anyway, we can see the record day by day at over 3 months now. We can see the record.
Okay. I think I think
Dr.
that's
Htun,
it.
Dr. Htun, maybe you can off your video because I think your signal is not very good. So that can you please repeat what you have just said?
Hello, is that okay?
Yeah, I think it's about whether you can confirm whether she's having true low hypos when you check the AccuCheck meter. When you go to the meter, are you able to do that?
Hello.
Oh, so Dr. Tun's internet connection might be. I think he said that he could check it from what I gathered.
Hi,
we have
Dr. May. It's just Tyler. I'm talking.
Tyler.
I'm the clinic support program manager for A4D, and I work closely with Dr. Htun, so I have a bit of knowledge on that. What he's saying, when he got cut off, he was saying that the units are in milligrams per deciliter.
Yep.
And yes, we can access. I believe it's about 500 historical readings on the meter. So he was saying that he has regularly cross-checked what's in the diary with what's on the meter, and he can sort of vouch that the patient is generally honest.
Okay.
So in that sense that he can get relatively accurate history.
Okay, thanks, Tyler. I think I did catch that, which brings us back to then it's too much insulin for her, which is my initial opinion. I know we've got Sonini here, who says that there's no dietitian or nutritionist in Myanmar, and Sonini is based in Myanmar. So thank you for that. Just to tell the rest of the audience, I think initially it would be really to reduce the insulin down, and it might be that she is over treating. She's constantly hypos. Maybe she just treats all her hypos continuously, but you're right. It's just slightly paradoxical because her HbA1c is very high. You would expect with so many hypos, you would get a lower HbA1c. Okay, so hi, Dr. Mani.
I'm sorry.
Were you saying something, Dr. Mani?
I was just wondering if the HbA1c can be vary with the time that the blood is withdrawn from the patient. Like if we withdraw the blood and then we keep it for 1 or 2 hours later to test for HbA1c, does that falsify the result?
Yeah. I think you mean the HbA1c test was 10 immediately or not after drawing out blood. Yeah, we have the portable HbA1c tester, and we can it's portable and we can do the test within 3 minutes. So it is 10 immediately after drawing out the blood.
Okay, we've got another comment from Prof. Blake, who says, is the lab able to measure fructosamine? So this is thinking outside of the box, whether the HbA1c is accurate or not. So it's some interesting comments here. Now I'm going to bring everyone back because we have one last speaker, which is Johanna. who needs to talk about Hello Type 1 voice and importance of the perspective from someone living with type 1 diabetes. And then I'll open the floor to everybody, and everyone put their videos on so we can have a good chat. So welcome Johanna Koh, who is our digital learning and development lead for A4D, and she'll be talking about Hello Type 1D voices. Thank you, Johanna.
Thank you for the kind introduction, Dr. May. Hello, everyone. Isn't it beautiful to be in this international call? I find it beautiful seeing a diverse group of respected healthcare professionals. So we are Hello Type 1. Next slide, please. We aim to promote Type 1 awareness and education across Southeast Asia. We speak Khmer, Swas Dai, Vietnamese, Xin Chào, and Thai, Sawati. Soon we will be speaking Bahasa Malay, Bahasa Indonesian, Burmese, Laotian, and Tagalog. Educating, engaging, and empowering the diabetes community is the heart and soul of Hello Type 1. The next slide, please. Okay. There. The Hello Type 1's ecosystem is in two platforms. First is the website, and second are the social media pages. We are using Facebook today. Soon we will add other channels. What's the difference? The website is like a library, contains articles, videos, quizzes, and posters, because the mission is to educate and inform. While the social media pages is where we engage and connect. The aim is to engage and empower people living with Type 1 and their families. In both platforms, we try to simplify the content. This is why we invite you to use them. They are not just free, but they are specially made for all of you as easy and quick tools you can access. Like while your patients are waiting in the waiting areas, they can view the videos. The posters can also be downloaded and printed in your clinics. Dr. May shared earlier what makes HT1 unique is that our contents came from validated sources. And this is a way to get peer support also. Eventually, empowered people living with diabetes can be their own ambassadors in your local communities. So we will help build them up. Next slide, please. Okay. Another beautiful factor, Hello Type 1 has a share of Type 1 voice. As Dr. Andrew mentioned earlier, a multidisciplinary team approach in diabetes management is highly endorsed. This means the team is not limited to healthcare professionals, but also the patients themselves. And results show encouraging outcome. This is true because I am a product of peer support in overcoming my struggles and stigmas I face as I'm on level 21. I've been with type 1 diabetes for 21 years. I live in the Philippines and I appreciate my healthcare team. I would say I have certain issues that I don't really open up to my healthcare professionals, not because they cannot provide solutions, but they're brilliant, It's just that it's for another call. So what do I do with those issues? In general, type 1 face different issues like mental health, diabetes, distress, stigma, complications, all those, disordered eating. Having those words doesn't even sound smooth, right? Like hearing me say it out now, it's so natural not to talk about it. Why? Could be scary, could be unsafe. The question is there a safe space to talk about this? If I talk about this, will I be judged? Will I be heard? Will I be comforted? Will I be empowered? Yes or no? Not sure, right? But there's something sure. A good place to share this will be among fellow type 1s through peer support. Changing behaviors overnight through formulas may not always be the fix, but we need to feel connected and supported. I have changed my behaviors through peer support, and this is why we are doing what we do, because it works. And can I share a popular international hashtag? It's called Nothing About Us Without Us. So let's be together. All of you can tell your patients and caregivers about Hello Type 1. If you would like to conduct a special peer support or a trial run, please reach out to us. It is Hello Type 1's heart and soul to educate, engage, and empower. Thank you, Professor May.
So thank you so much, Johanna. That's such a lovely, energetic presentation, and I love that because it really is so important that we involve people living with type 1 diabetes, and you're right. In parts of the world, it is a struggle and it is a stigma. So, and we have to bridge this gap that we see in Southeast Asia, where we're concentrating on supporting the community and people living with diabetes. Now I'm going to ask everyone to put on your videos if you can, open up for the Q&A session. I know we are slightly running out of time, but I'd love that we see everyone, and I'm sure AC wants to take a photo as well of everybody who's involved today. And there are two things I want to ask. We have always, in every network, I've asked if there are clinicians or dietitians or nurses or anyone in the healthcare professional MDT who would like to join a small working group. We do run interesting case dilemmas like that presented by Dr. Htun from Myanmar. And we do want a small group of us to gather our thoughts to give our colleagues and anyone who has interesting case dilemmas that they just need some help with, or they need, what are the things that we could do. I'm going to ask again at this network, because I ask at every network, if you are interested in joining a small clinical case dilemmas group, then please contact AC, and I'm sure Tyler, who leads the clinic support program, will get in touch with you, and we can bring in cases, or when we already have a case such as Dr. Thun's and we need to discuss a little bit more, or we have a case where we have difficulties moving on from basal bolus, from BD regimen. And we have another case, for example, who is a possible neonatal diabetes. And we have another case who's possible MODY. How do we stop insulin and move on to sulfonylureas? So these are all cases that are interesting, not common in your practices. And we need a group of clinical experts from all MDTs to work together to support the clinic support program patients. So if you're really interested, will you please contact AC, and I think, and Tyler, who leads the clinic support program, we will set up either ad hoc or occasional MDT Teams meetings so that we can all talk about these interesting cases, because really, sometimes I'm even at I really don't know what to do with this child. We don't have glibenclamide, we don't have gliclazide, and this child has a HNF4 at MODY. Well, what do we do in Southeast Asia? So you guys might have all these wonderful gems that we need help on. So I think it'll be fantastic because we have run it in the past, but at ad hoc basis, where we come across very interesting cases that we need the clinicians in Cambodia, Myanmar, Laos need support with. So please contact us. So I'm going to open the discussion. My first one actually is Andrew Tan's presentation was so fantastic. I just think we don't even have it in the UK. It's so amazing. And there's all these papers that shows that these pharmacies run clinics for diabetes has worked well. So I'm really interested in whether Laos, for example, Cambodia, Indonesia, do you have these clinic-led programs run by the pharmacists, or even Philippines? Do you have them? It's fantastic to see Andrew's presentation that they're so useful to support the patients as well as the actual clinics. Do you have them in Singapore?
Feel free to unmute and then say a comment.
Yeah, we're open for all. And
in Singapore, I understand that now one hospital who deals with adult patients with type 1 diabetes has involved pharmacists in their type 1 diabetes management. We don't have a direct involvement of pharmacists in our pediatric unit.
Okay, neither do we. And I don't think my UK adult diabetes service pass either. So I think it's such a fantastic extra support for the patients with diabetes. How about Dr. Mane or Dr. Ramouy in Cambodia? Do you have, or Dr. Agostini, do you have these clinics that seems to be really having some good outcomes? So run by the pharmacists, looking at adherence, looking at whether, because we know in research has been quoted that 80%, actually has non-adherence to medications. That's a lot, isn't it? 8 out of 10 patients don't adhere to their medications. We've all been patients. I'm sure we don't adhere as well. When, do we take our antibiotics the full 10-day course, whatever? So we know that that's high non-adherence. But it's fantastic, Andrew. Your presentation is, I think, it's really a sharing of best practice. And I wonder even if it could be, grouped together, Southeast Asia, those who have it, whether you could publish an experience paper about it, if you have some outcome data, Andrew. So just an idea.
May, actually, I have a question as well for Andrew. So I'm a pharmacist myself. And actually,
there you go.
yeah, I don't know if you knew it, but yeah. I have a question because, so I'm a French pharmacist, and in France we have, so you can be a normal pharmacist working in, let's say, a city pharmacy, or you can pass a different examination, a different competition exam to work at the hospital and to be, we call it biologist in France, pharmacist, biologist. Is it what you are? Is it a bit something similar, or any pharmacist can apply to be part of it?
Right. So just to clarify a bit, our DM Tech service in Malaysia, we are not directly dealing with the pediatric population, but as they move on to at the age of 12 years old, some of them will move on to the adult clinic. So we do have contact with type 1 patients then. But even then, not many facilities in Malaysia, I would say, are overseeing type 1 patients. But my hospital is one of it that does. And to answer AC's questions, this DM Tech service was initially established as a public healthcare service, right? So in Malaysia, in public healthcare, we have tertiary hospitals, we have primary health clinics. So we have pretty much expanded in the last decade or almost 2 decades throughout most of our clinics and hospitals. We have DM Tech services. However, in the community, I think in the last couple of years, there were some requests that these community pharmacists would come in to request for a training. So that has been done, but I'm not sure what's the number of the figure like. But we do have a couple of community pharmacists who have expressed their interest and have undergone some of the basic trainings. But in general, this service is mainly a public health service. Yeah.
It's still a fantastic, obviously Sarawak General Hospital is leading the way with this program. So I think it's fantastic to have this extra support for people living with diabetes. I don't know, Dr.
Can I just make one quick point on that one? Just from the patient's perspective, why a pharmacist is so important. As anybody who knows me will know, my whole thing about type 1 diabetes is motivation. You need motivation to control this condition. You need to stick the drugs in you to get better, and you can't guarantee that. One of my recent point of call is my own pharmacist, who tells me, Jerry, how's it going? Are you injecting? It's just another person who's giving me that message, and it's easy and it's accessible. And I think pharmacists are great. I see my pharmacist far more than I see my very busy and overworked doctor, because he or she doesn't have the time, but my pharmacist is there, and I meet them and they give me the drugs and they encourage me. So from the patient perspective, I think pharmacists are really important.
Thank you.
Absolutely. I think we've got Dr. Estrada, who's also noted that sometimes these clinics are also run by diabetes educators and dietitians. So I think regardless that extra bit of support, don't forget that they are licensed to also adjust medications. A peer-to-peer is different. It's a different kind of support, isn't it? And,
Yep.
and I think either one is a very important extra support system within the diabetes service. Dr. Quarry has noted something about neonatal diabetes and excellent on the diagnosis as well as the 4-month baby's recovery. So thank you for that message. We also support countries in SEA. If you think it's neonatal diabetes, it is likely not to be type 1 diabetes, as you know, yeah, if they're diagnosed. And if you're unable to send the bloods for the genetic MODY testing, because it is a huge impact. If, for example, it's a MODY, you might not need injections for life. You need a medication to open up the potassium channels. Then A4D actually supports the diagnosis as well. And we're trying to get one of the babies from Lao to be adequately diagnosed from the neonatal diabetes. And so thank you so much, Dr. Quarry from Indonesia. So opening up to the other 2 cases, can I ask if is cerebral edema a very rare condition that that you work with your intensive care colleagues with? This is from Dr. Ramouy's case. Do you use cerebral edema protocol from ISPAT? Anyone wants to just comment? These are cases that you really don't see often, and sometimes your fellow doctors or the doctors in emergency care would be seeing. And you're right, it's Dr. Ramouy's case was like, should we treat, should we not getting better? If you suspect it, then you go for it, because full-blown cerebral edema in DKA has a very poor prognosis, high mortality and high morbidity if they do develop that. And so thank you so much for that case. But please don't be shy. I don't. Dr. Agostini, I'm going to pick on you. How is Indonesia's? Because you have a very strong link with all your pediatric endocrinologists in Indonesia. Do you follow the ISPAT guidance? Do you have a national protocol?
So please, everyone can share your experience, because I don't want to careless for the next case. I can be better than before, because if we have made another case like us, the case I presented, it may be better for me and our team.
Yep. I think that'd be so. Please get in touch with Dr. Ramouy if you've got experience or regional protocols. Now, I know we are running quite late now, so I'd really like to thank everyone for your attendance today, and for those who have registered to view the recorded webinar. We have 120 over registered, the biggest so far, and I think it slightly a little bit rushed today, if I'm honest. So I'm going to rethink the agenda so that we have a lot more time to discuss the clinical case dilemmas, which I think are very interesting. So thank you so much to Andrew Tan, Dr. Ramouy, Dr. Htun, Johanna, for your fantastic presentations today. Thank you to everyone who has attended. Please get in touch if you want to present a best practice sharing, or you have an idea for a research publication. I've put on the note that we do help with genetic testing. So if Fiona, if you can put your email on the message there.
I have took down Dr. Quarry email,
okay.
so that will
Okay,
be on
great.
the to-do list.
Thanks so much. And thank you so much for all the representation. Dr. Estrada, another welcome from the Philippines, Dr.
Hi, Dr.
Agustini,
Sylvia.
welcome from Malaysia. And you know, I think we're getting every country now represented in SEA. So we'll be looking at you guys for our next network presentation. Is okay? Everyone put in a video. I think Rachel might want to just screenshot it for our newsletter, for just to say hi and have a big smile. Are you okay doing that, Rachel? To screenshot it?
Yeah. Maybe Fiona, if you don't mind,
Yeah, we'll help.
I'm recording the
Yeah.
video.
Okay.
Yeah.
Thanks.
Okay. Cool. So
Okay.
if everyone's
Okay,
able,
everyone smile. Okay,
Yeah,
1,
thanks.
2, 3.
Thanks.
Okay, again. 1, 2, 3.
1, 2, 3.
Hang on one more time. May, are you also doing it?
Me?
What is that? Okay, 1, 2,
times.
3. Thank you. So I
Okay.
mean, thanks very much for your participation. We will reach out to you from the Philippines, from the Indonesia, so that our next meeting, we will also have some sharing or maybe case from your country. Thank you very much for your time.
And
Thank
also
you,
next
everyone.
week,
It's lovely to see you guys.
yeah, and just want to add to that, next week I will send this recording to all of you, so you can just share it through the emails to your colleagues if you think that it was interesting to share. So don't hesitate. And I will contact you again for the
please
next
don't forget,
meeting.
yeah, I think please don't forget the bit about interesting case dilemmas. We have been running it, but there's been only 2 of us, and any so it'll be great to join a small group of clinical experts for these interesting case dilemmas, and Tyler and AC can organize the meetings, but like I said, then you can bring these case discussions then we have a lot more time to discuss about the details of the management. Yeah. Okay. Thank you again,
Thank you.
everyone.
Have a good weekend.
And have a great weekend.
Bye-bye.
Yeah.
Thank you very much.
Thank you.
Bye.
Bye-bye.